Good afternoon, and welcome to today's webinar, where we're going to take a closer look at urgent TAVR care and some of those clinical and operational strategies that help to improve patient outcomes. I'm Denise Bushman, Vice President of Care Transformation with MedAxiom, and I'm joined today by several excellent folks who know all about urgent TAVR care, along with Anna Mercurio Pinto, one of our other VPs of Care Transformation at MedAxiom. We're grateful to Edwards Life Sciences for their support. Today's webinar is reflective of material that will be forthcoming in the next couple of weeks in a business white paper outlining all the important operational and clinical aspects of delivering care to patients in need of urgent TAVR. So stay tuned for that. Those of you on the webinar will receive a heads up when that white paper is published. And other folks, there'll be an announcement through MedAxiom channels. So first of all, what I'd like to do is just introduce today's speakers. And they include Dr. Firas Zar. Dr. Zar was going to join us right away, but he is involved in a case. We hope he's able to join us in just a little bit. But stepping in for him kindly is Dr. Harsh Gawala. He is an assistant professor and structural heart program director at Oregon Health Sciences University. And Dr. John Nicholas Melvin, he's an adult cardiac surgeon at Memorial Cardiac and Vascular Institute at Memorial Healthcare in Hollywood, Florida. Also on the screen, you'll see Dr. Grant Reed. He's the program director for interventional cardiology fellowships and quality improvement officer for interventional cardiology section at the Cleveland Clinic in Cleveland, Ohio. And like any good interventional cardiologist, sometimes take call. And when you take call and you're an interventional cardiologist, there are STEMIs. And so he is currently in a STEMI case. And we also hope that he is able to join us. If he is not able to join us, I'll be presenting his slides. And then we hope to have him add his commentary toward the end of the presentation. So with that, just letting you know, these are the disclosures for our speakers today. And then lastly, just letting you know, as you navigate your way across the screen, you'll find that there's a link to the presentation that will be placed in the chat. You can click on that link in order to download a copy of today's slides. If you'd like to enter a question for any of our presenters today, please just click on the Q&A and type your question in. We will not have live questions, but we'd love to answer your question if you enter that into the Q&A section. So with that, what I'd like to do is hand it over to Dr. Gawala. Oh, no, sorry, not yet. I got way ahead of myself. What I'd like to do is just quickly set the stage for why it's important to talk about urgent TAVR. And that is to say, what we have learned is that when urgent TAVR is performed, the mortality incidence and the incidence of complications increases. We also see an increase in the length of stay, and you'll hear more about that from Dr. Gawala in just a few minutes. And we also know that the cost per case is increased notably. Furthermore, urgent TAVR, when performed, really does displace those elective procedures and adds complications when it comes to the clinical operations of the cath lab or hybrid OR. And it further strains capacity in terms of bed utilization and the ability to keep throughput moving forward. So setting the stage further, the challenge really becomes that we know many times larger referral centers have TAVRs that are urgent in terms of 1 in 4 TAVRs that occur at referral centers occur in already hospitalized patients. So that 25% historically has been, again, something that puts a strain on the system, but more importantly, has not necessarily been good for patients. And what we've learned is that, in fact, many of those patients can be stabilized and safely discharged for elective TAVR at another time. So determining urgency really requires a very nuanced, multidisciplinary approach. And what we hope to do today is to give you elements of what that multidisciplinary, nuanced approach looks like. So in the end, I think our key takeaway is what we've learned is that whenever possible, if we're able to stabilize that patient who needs a TAVR in advance of doing the TAVR on an urgent basis, stabilize the patient, and then bring them back for an elective procedure, we know that improves outcomes for all, and it improves sustainability for a program. So with that, what I'd like to do is hand it over to Dr. Gawala, who, like I mentioned, is already taking the place of Dr. Zar, and he's going to talk a little bit more about patient pathways. Dr. Gawala, thanks so much for joining us.
So here is
Dr. Zar, look at you. You just popped in the screen.
The two of us.
That's fabulous. Two for the price
guys.
of one. How good is that? So thank you so much. Glad you could step away from the case.
Thank you. And sorry for the confusion.
Not a problem. I'll advance your slide here.
Please. So I tell you guys a little bit about our program. We are heavily influenced by the by the national data. If we look at the TVT registry data, you'll see that the mortality for elective TAVR is around 1%. And as you do them more urgent, it's times 5. And if it's an emergent, it's times 17. And if it's salvaged, then it's almost times 25. So the risk of mortality exponentially goes higher as we take on those emergent cases. Next, please. And so this is our program. And we are about 300-400 TAVRs a year. We have 2 operators from interventional cardiology. We have 2 operators from surgery. And we have active efforts in decreasing our proportion of TAVRs that are done emergent. We were able to cut it from 7% to 5% in a span of a couple of years. Next, please. And the reason why we target that is because the outcomes are poor. This is our own data. Again, if you take our 30-day readmission for elective, if you take our any events that happen to our elective, if you take a 30-day survivor to our elective, it is significantly increased in urgent TAVR. And this was what we have noticed, and I think many people across service lines have noticed the increased risk that is associated with urgent TAVR. Next, please. Next, please. Next. Oh. And now if we look at the length of stay, whether we're talking about urgent TAVR, it's almost 8 days compared to outpatient TAVR that the length of stay is 1 day. And we've adopted a strategy also, we'll talk about it a little bit later, that we have the patient admitted, we get their inpatient workup, and then we discharge them. And then we do the TAVR on a subsequent hospitalization, preferably past 30 days. And those patients go back to a 1-day median length of stay as the TAVR becomes more elective. And that is via strategies of that we're going to discuss. Next, please. So the next few slides are going to offer some of what we have done in our system to address this issue. This is a complicated issue. We're not going to be able to solve it as an interventional or structural or service line focus on structural heart. We are going to need to educate our PCP, our cardiologists, about the importance of under recognition of the disease, early detection of the disease, looking at history. We don't like to be having surprises in patients showing up in our ED, and we find out that they have severe aortic stenosis. Next, please. So early recognition of aortic stenosis prevent those surprises. The surveillance, we have really educated all of our referring networks about what we do in terms of yearly follow-up, yearly echo, and we have structural referral pathway across primary care, cardiology, valve team. Everybody is welcome to bypass all of the red tape and just come straight to the multidisciplinary valve center if they have aortic stenosis. We get them from APP, from nurse practitioners, even from nurses, that the moment that it was detected, AS is detected in any of our facilities, in any of our subspecialties. Sometimes it's oncology. They're doing routine echo to watch the EF, and after chemotherapy, and they notice that there is AS. It does not matter. Everybody who has severe AS bypass the entire process of referral and come straight to the valve team. Next, please. So this structured outpatient was mirrored by a structured inpatient algorithm as well. So as soon as if somebody get hospitalized with AS, we get notified, we see those patients right away, we initiate GDMT, whatever they need, however sick they are, and then their testing get prioritized. So they get a CAT scan, they get an angiogram, they fly through our, I don't want to call it bureaucratic, but it is complicated health system to get patients in. But those AS get to the multidisciplinary heart team as fast as possible, whether they're inpatient or outpatient. Next, please. So this is, for example, a pathway for an urgent TAVR that get admitted. Patient get admitted, somebody flag it as severe AS, consult the valve team, we go see them right away. We put them on GDMT. If their EF is low, sometimes they need a BAV. Sometimes, we order their angiogram. We do all the diagnostics. We review them by heart team, and now we do that in a very fast sequence. Now, if they cannot leave the hospital, we can talk about getting them urgent TAVR. We try to minimize those, but if we do, we are doing them very, very quickly. And if we stabilize them, we would like them to leave the hospital on medical therapy and come back and get their TAVR at a later date. Next, please. So, an example, Dr. Gawal and I were thinking about a patient last month, came in, severe coronary artery disease, got a severe aortic stenosis, was presented the same day to the heart team. The decision was TAVR PCI, got an Impella, BAV, PCI to the left main, was discharged, was brought in 6 weeks later and got TAVR and got a good outcome. And that patient's length of stay for TAVR was 1 day. Next, please. I think this is all what we have for you guys, and we'll pass it along to
That's great.
some leaders who do even better job.
Yeah. Well, you're going to hand it off to me. As I was mentioning earlier, that Dr. Reed is doing a STEMI case right now, and we hope that he is able to join us eventually. So as I pointed out, I'm speaking for Dr. Reed's content. This is based on the material that we have learned about while forming the white paper.
Do you want me to speak for Grant? I'll be happy to.
Sure, you know Grant, so go ahead,
I know
Dr.
Grant very well.
Yeah, that'd be terrific.
I'm gonna impersonate Grant and say how great OHSU is.
I'm sure we'll let him be the judge of that, but you go
So
right
I tell
ahead.
you, Grant and us work very, 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 very closely. And whether it's a structured program or a service line or a quality, we have done significant work to create a identification of patients who are in shock. So, many patients, despite all of the process that we have, get hospitalized, they are in shock, and we miss them somehow. We try to provide temporary hemodynamic improvement, and Grant has been a leader in timing and employing a strategy around valvuloplasty. I do believe that all of us, I've read his paper and I learned from his strategy about how to offer valvuloplasty, for those patients, get them out of the hospital and get them follow-up. Next, please. So this is, Grant's algorithm, and I don't think that if you follow this algorithm, you will find something that you have not thought of. But when you put it in front of you like that, you will realize that if you have a patient who is hospitalized, sick with aortic stenosis, if you think that they're not salvageable and a BAV, offer them BAV and see how they do. A lot of them have severe pulmonary hypertension, maybe some renal failure that you needed to recover. You're not sure about the outcome of the comorbidities. We offer them BAV and we see how how they do. Now, if they're not eligible, or even if they're eligible, there is nothing wrong with the BAV as a bridge to palliative care. Patients do not need to die miserable. They can be optimized medically, and BAV help with that. It has been shown multiple times, and this is prior to the TAVR era, that BAV does not improve survival. And in fact, if you look at the partner 1 data, half of the patients that were treated in the medical therapy arm got a BAV. It does not improve survival, but it will improve, symptoms, and it will make patients maybe less symptomatic as they are dealing with their terminal disease. Now, a lot of those patients get a bridge to TAVR or SAVR after that by a hemodynamic, if they are hemodynamically unstable, with a stabilization of BAV. BAV is also utilized if needed for a high-risk PCI, if those patients need coronary revascularization. And really, I mean, Grant and many others in the country have implemented BAV as a step in the hemodynamically unstable patient to stabilize them. It is different than the old era of BAV when we used to do blindly. A lot of those patients right now, we have an idea about their sizes, you know, the aortic annulus, and we can achieve better outcome. Next, please. All right, so this is Grant's data, and you'll see that again, if we look at in-hospital mortality, urgent TAVR versus BAV before TAVR, it's almost a third. 90-day mortality, same story. Length of stay, same story. TAVR hospitalization cost for BAV, you'll see the difference between if you do a BAV versus if you do TAVR. So really, if you adopt that strategy, and we do, and I know many of those on the call, have them done in their hospital, is not only good for your economic, but it's also good for your length of stay and patient outcomes around mortality. Next, please. So I do not have a great story to share about Grant. All my stories about him are personal, and I don't think they're appropriate, but I will tell you there are many stories that I know that have used BAV to bridge patients successfully for TAVR. And I will not be surprised if the case that he's doing right now and that prevented him from being on this call feeds in that category.
Very good. Thank you. Dr. Gawala, did you say you had a story in regards to the use of BAV pre-TAVR?
Yeah, I mean, there are plenty of cases like that. I mean, several examples come into the mind is, when Grant mentioned in his slide set, there's always sometimes discordance between the category of AS, low flow, low gradient, versus the patient has low EF and mild aortic stenosis or moderate aortic stenosis. In those cases as well, we consider the balloon valvuloplasty and get the patient out or get the patient off the pressors and optimize the GDMT and see how they do. That's one of the stories I will say is that comes up very frequently is the guy is in ICU and is on a pressor or a couple of pressors and inotropes, and EF is 20% and the gradient is 20, and the inpatient team tells you the patient has low flow, low gradient, severe AS, and you can't really ascertain the diagnosis of low flow, low gradient. In those cases, I have done the BAV to see if these patients improve and can get out of the hospital rather than subjecting them to urgent TAVR, because TAVR outcomes in that particular patient population are not great because their whole original problem is cardiomyopathy as opposed to just a pure AS problem.
Mm-hmm. Yeah, really important in terms of better ascertaining the real problem, if you will, that's behind the symptomatic piece of AS. So thank you for sharing that story. I'm now going to hand it over to Dr. Melvin. Dr. Melvin, interested in hearing a little bit more about how you've managed those urgent TAVR cases as well.
Yeah, hearkening back to the VAV comments, while there may not be an improvement in survival of the patient, you can see the difference where the VAV and its utility can actually help the program survive, especially when you talk about having such thin margins. We kind of grouped that VAV strategy into maybe 3 different classes. During our heart team discussions, we talked about stabilizing the patient, getting them out of shock as best you can, improving upon the patient as they come to you, whether that be infection or malnutrition, what have you, and then being able to buy time and really addressing any sort of underlying pathology that you can or cannot do something about. I'm an adult cardiac surgeon at Memorial Regional Hospital down in South Florida and Hollywood, Florida. If you want to go to the next slide. Being that we're not a large academic center like Oregon and Cleveland Clinic, at least thought it'd be prudent to tell you who we are. So we go by the umbrella of Memorial Healthcare, but we're essentially South Broward Hospital District. We're established in '53 as a publicly funded community hospital system. It's one of the largest public healthcare systems in the nation. We're comprised of 5 community hospitals, including regional Southwest, Miramar, and Pembroke. We do single center cardiac surgery at our regional hospital. We also have a strong affiliation with Joe DiMaggio Children's Hospital right next door. We do advanced heart failure within this umbrella, and we're one of the only adult heart transplant programs south of Orlando. Supporting this further is, we've been able to achieve and attain the gold level of excellence for ECMO. And recently, we're able to achieve a couple ACC designations, most recently the ACC Healthcare Center National Distinction of Excellence, as well as the ACC TAP PCI in 2023 and heart failure in 2021. Advance. So we're not as large or due to volume. We're probably around half the volume as mentioned previously. We started commercial TAVR in 2012. In June, it run about 150 or so TAVR per year with incremental growth here or there. We have 3 cardiac surgeons, including myself, who participate with 4 interventionalists. And even within that umbrella, we have 2 private interventionalists that operate within our heart team and take care of about 25% of our volume. Overall, our mean hospital length of stay in the previous quarter was about 1.7 days. So we're not discharging people immediately, as is supported in some academic centers. If you want to go back real quick. But we do try to do everything that was reviewed earlier in terms of helping facilitate and streamline our patient access. Our valve coordinator role is comprised of 3 individuals, 1 RN and 2 nurse practitioners that we utilize, especially within an Epic system, to help take ownership of these patients as soon as they're really referred to one of us as operators. So anyone who would hit the mark in terms of a TAVR referral, we reach out to these individuals within an Epic chat, what have you, to really have someone take ownership of getting them through the process, usually helping get scheduling done ASAP, etc. Our heart team is what I feel to be the strongest about our program because we have a lot of buy-in. So you can see our little WebEx chat list there on the right side. So this is truly fully multidisciplinary and very responsive. So in addition to cardiac surgery, general cardiology, interventional cardiology, we also have good buy-in from heart failure, cardiac imaging. We do have cardiac anesthesia that participates, but also our administrators that help kind of actively almost survey or patrol or serve as a resource for us when we see cases deviating, maybe outcomes deviating. We have those resources really at our disposal within our heart team already that we don't have to reach out and seek out, access and attention elsewhere. We do have kind of core availability on Tuesdays and Wednesdays, but we do and can have capacity for added cases like on a Friday. And we do exercise kind of the ad hoc, emergent reviews on some of these patients, especially these very sick patients who can't otherwise leave the hospital. I think the most recent was even yesterday. Next slide, please. We get a very sick demographic here. Everyone says that, but you can look at our low risk TAVR numbers, and really we're even lower than the national benchmark more recently, 27%. A lot of folks in South Florida, we find, basically have late referral, late access, and unfortunately, can come in even more sick. The more stable patient coming to your office, walking into your office, that has had a heart murmur that they've known about for a while and have been actively engaged with their cardiologist, just doesn't seem to happen as frequently as what I remember in working in more northern institutions, etc. But we'll look at that eventually. In terms of our program breakdown, we're about 82-83% balloon expandable valves, consistent with the Edwards sponsorship here. But we do plenty of self-expanding valves as well. So strategies to help improve workflows, I think, are very institution specific. But essentially, if you look at the data presented earlier, that the sicker patient stays longer and costs more money. So each operational feedback system is trying to serve the overall system capacity. So fewer urgent cases, free up procedure time, reduce hospital length of stay, improve efficiencies, which I know, we all look at ways every day to improve how we can conduct a case turnover room, decrease costs overall, again, because the profit margins are very, very narrow. And when you have administrators helping you identify where those costs start to deviate, you really do help to appreciate the impact that these urgent TAVRs and patients with advanced heart failure are really having on your system. So essentially, we're trying to improve upon margin, but also improve upon true patient outcome. Next slide. So our TAVR coordinators, as I mentioned, we try to batch into our Epic access. So we reach out to them directly, and what I'm looking for out of them is true ownership of the patients throughout the entire process. I can refer to them as a quarterback. So they guide the patients through the initial assessment, plug in these patients, whether that be as an inpatient or outpatient, and really help get the bag of testing done that's necessary. They're organizing communication, not just between us and the patient, but also all the referrals, helping clear, the hurdles in terms of insurance coverage, et cetera. And then they serve with us in these TAVR meetings to advocate for the patients. And during these multidisciplinary discussions, they're really helping facilitate that forward progress and getting these patients ultimately safely into the cath lab and to get done. And optimizing all of the structure obviously will minimize delays in care and increase efficiencies. Next slide. So operational flexibility and capacity management. So escalation protocols, as I mentioned, kind of an ad hoc coordination. So, we're certainly not the only system to review patients kind of on the fly if there's somebody crashing and burning and they otherwise can't go home. And we've done everything that we can to maximize their stability. There's certainly formal algorithms. We definitely have utilized Dr. Reed's algorithm, kind of made some nuanced changes that we use here locally. And then, as I mentioned, there's a great deal of buy-in from the administration. So it really helps us in terms of maintaining some degree of flexibility to get into rooms and work on overbooking and really making sure that sick patients can get done as soon as we can. Next slide, I'm sorry. So if you want to go back, last one, we essentially, when I started this hospital almost 3 years ago, we were doing a lot of inpatient TAVRs and they were incredibly sick. And when I got here, I just kind of chalked it up to being in a more acute hospital than I was last time. However, when we finally started looking at our numbers, we were appreciating that we were well deviating from what the expectation should be. So inpatient TAVR is approaching even 25%. So as I mentioned, that heart team structure is incredibly beneficial for us here. And we were able to get easy buy-in from administration. We were able to advocate and re-explore different tools such as BAV. I think there's been a drift so long in terms of utilization of BAV kind of in the general community that we really just represented the data and say, this is a safe strategy, especially for an otherwise sick patient who might die of something else than just aortic stenosis. By reducing, so length of stay reduction, we found, 37% reduction in direct costs associated, and avoiding each urgent case does save $16,000, which obviously makes sense. These are incredibly expensive hospitalizations. And the more efficient that you can get with scheduling and workflows, you can reduce disruptions elsewise and elsewhere across the board, whether that be with your vascular surgery teams or your interventional cardiology teams elsewhere. And you can really improve upon, having an organized structure that gets done efficiently and takes good care of patients. Next slide. That was kind of the story that I mentioned in terms of having good buy-in from a heart team and having active improvement processes to recognize that patients, palliative care and BAV and, all the like, and good heart failure services can help stabilize patients instead of just trying to put a new valve in a crashing and burning patient.
I'll just step in here for just a moment. I see Dr. Reed was able to join us, so delighted that your case ended in a timely enough fashion, Dr. Reed. Now, Dr. Czar threatened to tell some stories, but he restrained himself. So before we get into too many key takeaways, I know that you really have a lot of expertise in BAV, Dr. Czar. did cover those slides. I'd be happy to back up if you'd like me to, or if you can just kind of riff on things. Curious a little bit more about how you found BAV to work effectively in your patient population, and even how that really has synergism with other ways in which patients can be stabilized and prehabbed, if you will, once they do receive BAV, what they do on that outpatient basis prior to coming in, or other ways in which they might be stabilized in addition to BAV. So take it away here for a couple minutes for us.
Wonderful. Well, thank you guys very much for putting this together. To all of us on the panel, it's really my honor to be speaking with you on behalf of these important topics. It's really it's very heartening and exciting that there'd be so many in attendance who are interested in how to improve operational efficiency and how do we improve outcomes for patients with aortic valve disease. So at our center, and I think at all centers, I think it's both a good and a bad problem to have. There are so many patients with aortic valve disease that need treatment. At least when I started as staff here in 2018, it's hard to believe, already about 7 to 8 years ago. This is really when we were moving from into the medium risk era. And there seemed to be an explosion of TAVR patients, or patients who needed and were qualified for aortic valve treatment. So the needs kind of outstripped our capacity for a short period of time. So we ended up, and I came into my practice actually doing quite a bit of balloon aortic valvuloplasty just to kind of help to bridge patients as a triage strategy, because we didn't have, one, the bandwidth, and two, a lot of patients are being referred that were maybe a little too sick for TAVR, with other medical issues, or in cardiogenic shock and needed to be temporized. The first I think year of my practice, I did probably more balloon aortic valvuloplasty just about anyone in the country, by the virtue of being here at the clinic. And I think that it really gave me comfort with the procedure. And also, it allowed us to analyze our outcomes from a system perspective. So we put together a lot of papers on this, both using administrative data from large databases like the National Inpatient Sample, like NIS, NRD, and Trinetics, but also our institutional data with granular outcomes. And what we've been able to show is really, I think, encouraging that BAV is a safe procedure, and that in appropriate candidates, it can be useful as a bridge to definitive therapy. Now, I would not advocate for it to be the only treatment, nor would I advocate that everybody needs it prior to undergoing TAVR. But I think as TAVR volume is growing, the number of patients we're encountering with severe aortic stenosis is growing, and not everyone is going to be an optimal candidate right away. And those are patients that maybe the valvuloplasty can serve a role. In specific, those patients are, again, not everyone needs to be perfectly optimized for TAVR, undergo a TAVR, but those may be patients who are like inpatient with an infection, has severe aortic valve stenosis, and are recovering from a diverticulitis, and not quite there yet, but do need the aortic valve treated, may have concomitant heart failure and recovering sepsis, or may have a mixed form of cardiogenic shock, which you're not sure if the aortic valve stenosis is driving it, or perhaps other medical issues which would preclude TAVR at the time. It's not an insignificant number of patients, and there are data that I think are supportive of doing TAVR, even in patients with cardiogenic shock, and outcomes are, I think, acceptable. However, in our patient population, we've shown that in the short term, out to about a month, outcomes between TAVR and BAV are about the same, and it's really after a month when outcomes start to diverge, meaning that if you can get someone out of shock in the short term, then their outcomes are the same as if they had TAVR in the short term, but you really got to do definitive valve replacement after about a month. Between 30 and 90 days is when outcomes really diverge again. So, if you were to use these data as a strategy, you can say, listen, we're going to do the valvuloplasty to get you out of your acute critical illness, to make sure that, one, you benefit from aortic valve intervention, and then two, do it in a more safe, controlled fashion to do the TAVR, which I think is a much bigger procedure than balloon aortic valvuloplasty is. As long as you can do that within a short window of time in patients who are in shock, then I think it makes sense to use that as a strategy. The other patient population that we do it in are those patients who are inpatients, and it has a little bit of a triage decision about, like, if there's scheduling issues. We don't get into that issue a lot anymore. And I think it's because we went through our growing pains, and we've since been able to, I think, not have to use BAV in lieu of TAVR. But there are, of course, patients who the diagnosis is ambiguous. So rather than kind of, continue down these, various pathways, I think I'll leave it at that. And you guys, please do let me know if there's a certain, area within this that you would want to dive into. But I think that, a lot of folks would, I think the perception of maybe outsiders looking in is that, well, because TAVR now exists, no one should get a BAV. And that's not true. And in fact, I think you're doing your patients a disservice if just everyone goes right to TAVR, because it is a bigger procedure. Patients may not be able to tolerate it. It may not be the right move for some patients. You'll be able to use BAV as both a diagnostic and a therapeutic tool in patients who maybe have another or maybe ambiguous diagnosis. And, you don't want to just jump to TAVR if they have a medical issue, which would otherwise preclude it. I think that it is a really useful strategy for a handful of patients, not the majority, but some. And, we still do it a good amount at my center for that very reason.
That's really great. Thank you so much for stepping in here and sharing a little bit more about your experience. You've been looking at some of the key takeaways here, just in terms of, we've talked a lot about procedural urgency and the nuance that it requires, and the importance of standardizing those decision points. I think we were just hearing a lot about BAV and those decision points, but also the earlier triage when patients arrive in our system, and the kind of care that's most helpful to them, be it starting with good guideline-directed medical therapy, such as diuretics and cardiac rehab if they're on the outpatient side, as well as other good heart failure therapies and appropriate diagnostics to truly understand the nature of their symptoms. And then using BAV judiciously to convert patients to a more stable point in their trajectory, and using it as a bridge to help us have a better outcome when they are appropriate for TAVR. And using good operational discipline to promote patient-centered sustainable care, as Dr. Melvin was pointing out, utilizing heart team conversations, that good multidisciplinary care supported by TAVR coordinators. So it's all part of strong leadership, teamwork, and transparency, really, as to what our outcomes look like that help us drive success. So just a few other just take-home points. If we start to think about what does the future look like, some of those opportunities that we know are there is broader adoption of echo surveillance programs that Dr. Czar mentioned. Unfortunately, we know a lot of times people just go unrecognized, and that's one of the efforts of the AHA's Target AS program, is to really make sure we have the right strategies in place to make sure patients are identified early so that we can intervene with the appropriate therapy as quickly as possible. And using more formalized inpatient TAVR decision algorithms, such as you've heard about today, so that you can take both those clinical factors, logistical factors, and then the social determinants of health that help guide the appropriate therapy for patients. And then whenever possible, looking at EHR-based alerts, integration of predictive analytics that might be helpful within the echocardiogram, or other ways in which we better understand the nature of a high-risk aortic stenosis patient before they deteriorate to the point where their clinical outcomes are impacted even after the TAVR. And then certainly always, as we just mentioned, monitoring what those patient metrics look like to understand what we might be able to do better. So what I'm going to do now is I'm just going to ask our panelists if they could come back on camera and join me. And also joining us is Michelle Slane. She is the Vice President of Cardiac and Vascular, the Cardiac and Vascular Institute at Memorial Healthcare System, because we've got some really excellent physicians that are here. And it's also, as we believe at MedAxiom, that dyad partnership is vital in promoting good care. So with that, Anna, I know you've been kind of keeping an eye on the question and answer portion. What questions do you have that we might want to ask any of our panelists here?
So thank you, Denise. That was great, all of you. Thank you very much. I do want to follow up on what you just talked about, Denise. You mentioned the techniques for diuretics, cardiac rehab. How are those used to stabilize your BAV patients prior to TAVR? Do you guys tap into that? Is that frequently used?
It's a free for all, so go ahead, whoever wants to go first.
Sure, I can jump in because I was late to join, and I apologize if it's already been discussed within the conversation on balloon aortic valvuloplasty. But I think that the role of BAV really, I think it should be viewed as really just that, either a diagnostic maneuver in patients who have moderate to severe aortic stenosis, so you're not sure it's going to benefit, or a therapeutic maneuver to one bridge through like a non-cardiac surgery, which is more urgent, or in the acute setting of someone who's in a cardiogenic shock and maybe is very high risk for TAVR, and you want to be, a steward of resources. So, diuretics and medical optimization prior to the treatment of patients with valvuloplasty, I think, are important. Absolutely. I think patients should be optimizing guideline-directed medical therapy all the time, for sure. But I think that there's also some recognition that in patients with aortic valve stenosis, you're often quite limited in your ability to do so because it's a mechanical obstruction to flow, and diuretics may, although in the short term help with symptom management, there's a serious risk of decreasing the preload and then causing complications if you're not careful. So diuresing patients with severe aortic stenosis, indeed critical aortic stenosis, and especially patients with cardiogenic shock, it can be really difficult. So I try to, be somewhat judicious about that. And I don't, in fact, when I do valvuloplasties, the majority of patients are not optimized in any way because we're trying to get them through an acute situation. And then oftentimes after, then they can be optimized. So, I was telling my fellows that doing a valvuloplasty is kind of like being in the Marines, like you kind of are in there in the trenches. You're doing real sick patients. The patients are often much sicker than they are if they undergo TAVR, and you're kind of in the trenches a bit, and you have to be ready for everything that can happen in that setting. So most patients are kind of the opposite of optimized, but if at all possible, of course, would advocate for that to the extent that you can. But you just may never really get there. In these patients, I wouldn't wait too long to offer them treatment.
Great, thanks. Anna, is there other questions that we've got that have come in here?
Yeah, so a question, as you know, a lot of our audience are also operational administrative folks. So we were wondering about the relationship between anesthesia and echo when this is a very time-sensitive situation. How is the collaboration? Have you guys figured out the magic sauce to making that work?
Michelle, can I dare ask you to take a stab at that from an operational standpoint, and then we can ask Dr. Zar, Dr. Melvin what they think too, from a clinician standpoint.
Well, everybody has to be committed, and we have our structural heart team, our multidisciplinary team, and everybody has to participate. And so when things happen and we have to do an urgent TAVR or whatever, we just go to everybody. It's just have open communication. That is the most important thing about having TAVR patients. Open communication, getting people involved, and doing what's right for the patient. So it makes it easy that I'm over the echo department in the CVI, so they're very responsive to what we need to have done. So
really important. Go ahead, Dr. Melvin.
So our system does support cardiac anesthesia with our patients. So I think, again, that's kind of where we may deviate a little bit from the larger academic institutions. I trained at Emory, so we throw a little local in the groins and call anesthesia if we got in trouble, with bedside transthoracic echo. So the benefit that we have through the investment is having cardiac anesthesia immediately there, and if somebody needs to be transitioned from a MAC to a general, it's going to be done, and we have the capacity to do it immediately. which can be very helpful for, the urgent TAVRs in these patients who are otherwise in shock and need a lot more. So we do have tremendous capacity on that end of things with very good cardiac anesthesiologists. And we usually have a member of their team kind of participate in our heart team meetings to identify maybe some unique obstacles. I try to advertise that, our heart team has a lot of buy-in. It has a lot of people with different skill sets. So it's not just surgeons, it's not just cardiologists, but the question about, optimizing patients, they're on the call in our heart team meeting. So heart failure is there. Ask them, have we maximized what we can do? As Dr. Reed identified, these patients typically don't really have a whole lot of leeway left. They're kind of in the last throes of their, usually critical aortic stenosis. So it's good to just have the ideas in the room, and it's good to have institutional support to say, we're not going to limit you on one side of things. And because they do recognize that this is a very valuable patient, unfortunately, and if it goes poorly, it's going to cost everybody.
Mm-hmm. Yeah, interesting. I just a follow up to that when we're talking about stabilizing patients. And Dr. Zara, I see you're back here on screen here. I know you at Oregon have done a lot of work in terms of, as you have at Cleveland, Dr. Reed, in terms of coordinating with referral patients. So if you've got that patient in an outlying center, how do you, some people, may not want to refer the patient until they know you're going to do the procedure right away. How do you work with those other referring institutions in terms of understanding how best to stabilize the patient where they're at before transferring? Or could you share a little bit about what that interplay is like with those referring physicians?
Sorry.
There you go.
I appreciate the comment, and I think it is challenging at times. I think the belief that we on, and I think John has articulated it very well, is that we're all trying to do the same thing, which is deliver good outcome in a timely manner and be fiscally and outcome responsible. And I think that is what put us together. I do believe that any of the referring facility, whenever they meet somebody with aortic stenosis, the goal is to deliver the best care as fast as possible to those patients. I do not think that people intentionally hold on to them. I don't think that people are intentionally not treating them. And I think the moment that you educate them, and also you have to alert your internal team that whenever you get a patient from so-and-so, or you get a patient with severe aortic stenosis, like those guys be prioritized at your transfer list, almost every day count. And, we try to stabilize them, whether it's they're needing diuretics and such. But the moment that fails, beyond just a simple heart failure hospitalization, we're right on it. Get them transferred, as Josh beautifully described, get them a BAV if need be, and optimize them. And we don't delay that. And I think once the referring facility understand our goal and the strategy, they are right on board with it.
Yeah, very good. Yeah, important comments there. And in the importance of making sure that they're well stabilized, before they come to your facility as well. That just makes them better off. Anna, other questions that we might have? We've got a few minutes yet where we can ask.
Yeah, Dr. Melvin, this one's specific to you. You mentioned that you have a couple of outside interventionalists as part of your group. So tell us about how you incorporate them and know that they're on the same page as your core team in taking care of those patients, especially when it's all about the relationships, right?
Caught that, didn't you?
I did.
So when you have physicians who are in private practice and they're participating on the team, it is a fine balance. So everyone on a heart team needs to buy in, and it doesn't matter if you're, the VC putting up the PowerPoint on the monitor, or if it's the outside interventionalist, it's the cardiac surgery team here, anesthesia, whoever, right? So we all need to be on the same page, and we all have to have the same goals in mind. And as I kind of emphasized earlier, the margins are small, so we're going to be running some narrow margins across the board. And if you want to continue to put in valves, everyone has to be very diligent about who they're targeting and how they're taking care of patients up front and out the door. So So yeah, we essentially have to do a fair amount of QI, look at our own numbers. You don't call people out if they deviate, but you definitely identify drift within the program. And it's great to have Michelle on the call, and it identifies kind of the role of administration to really be a part of that conversation. So it's one thing to be a cardiac surgeon and telling an interventionalist, hey, you're bringing in trash and ultimately destroying our program. You can't do that, right? You're going to miss out on that bag of patients eventually, right? But if you have the entire heart team who's sitting there on a phone call and they throw up a bunch of numbers and there's a massive shift and deviation, and you can follow trends. People know what they're talking about. So it's great to have the administration support on that end of the conversation. And again, this is part of maybe our ad in this conversation. There are two awesome academic centers that kind of paved the way in terms of how to be on the cutting edge of therapy. But then, there's also large community hospital systems throughout the country that maybe have a different mix of both providers as well as patients. So, identifying the best ways about developing universal, operational efficiencies, I think is valuable to everybody.
I appreciate that was part of the reason I was asking, because we now know this, TAVR is now very sophisticated and there's many people, but there's also a lot of new community hospitals who are tapping into it, right? So they have a lot of outside docs, and we need to figure out how to engage as many as possible, at the same time continue to grow and learn and have the hard conversations, right, Dr. Melvin?
Yeah, I think team membership, right? A lot of us grow up as athletes, so there's a lot more weight that is delivered when you start talking about a heart team. And so much as that's being emphasized, and the benefit of serving on the team and having good outcomes for the team and keeping that team alive and viable, I think all of it's very valuable.
Even though, we at Memorial, we have like a hybrid. Our cardiac surgeons are employed by the healthcare system. And I think that also helps with the checks and balance. So we just won't let any interventionalist come on staff and do TAVR. There's certain criteria, obviously, that they have to meet. But I do feel like our cardiac surgeons do keep the interventionalist also in check. And that's all about communication and relationships.
One of the other things I wonder if we could just touch on momentarily, Dr. Reed, I know you and I, when we had our interview, you talked a little bit about some of the lab strategies when we're talking about doing these urgent procedures, and how do we make sure that there's space to do those procedures in the lab? So you just had an emergency. I know Dr. Zar was involved in a case. So these labs are very busy. What have been some of the strategies in which you've been able to make these urgent cases fit? Or is that, or even to do that more urgent BAV to get done? Could you talk a little bit about some of the lab structures that work?
Yeah, so I think you need to be very intentional about how you're going to handle urgent procedures, whether they be STEMIs, which I just treated a patient with a left main occlusion, and they're doing okay, thank God, or a valvuloplasty, which may not be quite as emergent as that, but still something that needs to be done in a hospital setting and maybe time sensitive in someone who's in cardiogenic shock. So I think reserving some lab time for these urgent cases is actually quite important, and prioritizing them and understanding that BAV is not the same as doing a diagnostic cath. You need to reserve some time, and generally speaking, it doesn't take me more than about an hour. And oftentimes much less to do a valvuloplasty. Do it well if you're doing a diagnostic left and a right heart catheterization and measuring aortic valve area. It can take a bit of time. The reimbursement is much better as well. So, not that should drive our decision making, but it's also somewhat of a recognition to administrators, perhaps that, the saving time for this will be financially beneficial too. Because, you may get approximately 30 RVUs from doing a left and right heart cath in a valvuloplasty. And, that is essentially the equivalent of 4 or 5 left heart catheterization. So I think making the argument that it's financially smart to do so, because these are not procedures that you want to let go of. And, if patients can benefit, as I think we've shown, but also it's a good use of time, for our cath labs.
Yeah.
Yeah, and there were actually some really intelligent questions asked in the group chat. And a couple of them really revolve around risks. And I can share a couple of the publications that we've put together in our group just about what the risks of BAV really are. And I think that helps understand that if you were to take, the BAV patient population, they're in general sicker than the TAVR population is, or at least in our institution, meaning much more, more inpatients, more cardiogenic shock patients. But even with that, the risks of mortality, in-hospital mortality is actually, not insignificant, but most patients would have passed away even if they didn't get to BAV. So it's important to recognize that. The things like vascular complications, though, stroke, pacemaker risks, in general, they're about half of what they would be with TAVR, believe it or not. Stroke risk is probably about 1%, less than 1%. Pacemaker risk is lower, actually about 5%. And major vascular complications are uncommon. So, say about 10% of TAVR patients, probably about 5 to 10% with BAV. So there is no free lunch. But acute AR, which is one of the questions, is very uncommon. I don't do it in patients that have moderate or worse AR for that very reason. In really high-risk situations, of course, it's wise to have a rep on standby, but I don't usually do so. Inpatient TAVR is another question of when do you offer that after valvuloplasty. I think if you're using the BAV as like a really almost, not to say it should be like a Darwinian selection, like process, like if you start the BAV, then you're going to do well enough to get the TAVR. It is a little bit Darwinian if you think about it. And I think the mindset rather should be that, you may not survive the TAVR right now with rapid pacing or with a self-expanding platform completely obstructing flow. Patients in shock, you want to make sure that you get them tuned up as much as you can, right? And I think that you should offer that TAVR to them as soon as you feel clinically appropriate. I would not drag your feet. In a shock patient, if you can do it within 30 days, definitive AVR, the outcomes are the same as compared to patients who just had TAVR who weren't in shock. But a lot of that is also self-selection, right? Patients are going to tell you if they're well enough to get the TAVR or not. And some patients, unfortunately, are going to dwindle. And, so you have to understand and try to conceptualize whether or not intervening on the valve is going to change their trajectory or not. And those patients that you think it will, then you should do the TAVR as soon as you feel comfortable. But I would try to get it done closer to 30 days rather than 90 days. Yeah. I think that there should be an understanding. Not to say everyone needs a BAV, but just to understand it is not as risky as TAVR is. It's just not. And in the contemporary era, especially with some of the smaller balloons, you can do BAV with an 8 French sheath. If you do it well and you're careful, you should, it'll save your patients some complications opposed to if you were just doing urgent TAVR. So again, not everyone needs it. I'm not advocating for it. I don't want to come across too strongly here, but I also want to make sure that everyone knows it is a valuable tool, and it's a good use of time for the lab for patients who really need it.
Yeah, great. We are about at the end. Dr. Zar, go ahead. Looks like you're reaching for the microphone there.
Yeah, I mean, I just want to say one comment, and I hope the three of us in our representative programs, we emphasize the importance that it's not one tool. It's exactly what Grant is saying. It is toolbox that start with referral. Some of it is internal, some of it is external. Some of it is medical, some of it is interventionals like BAV. But I think that there's a lot of work that can be done in order to optimize the outcomes for those patients. I mean, we summarized it in a different scope, but there's actually a lot more above and beyond of what other people can creatively think how they can be managing it in their own program.
Right. Well, that's a great place to land. It's 5 o'clock. And so we've kind of come to the end of our time. We're really delighted everyone has joined us today. As you've seen on your screen, coming soon will be the Urgent TAVR Care Business White Paper that Dr. Melvin, Dr. Reed, and Dr. Zar have all, and Michelle, and I'm blanking, Dr. Zar, on your administrator's name, so I apologize.
Kim.
But
Kim.
yes. Oh, thank you. Yes. But all that is to say, we had a broad participation. Wanted to give an understanding of this process from a variety of perspectives. So that will be forthcoming soon. So keep an eye out for that. And again, thanks to our panelists for their insights today and for the questions that came in and for your participation being here. So with that, thank you and have a good evening.
Thank you so much.
All right.
Yeah.